Very good afternoon to all esteemed colleagues and faculties and the guest of honor. Definitely mental health and communication and, things are gradually entering into the field of oncology. So it is extremely important that we take this forward to mental health professionals, to oncologists, as well as to the community, so that we can get everybody together to create a team, because psycho-oncology as a subject is not possible for somebody to do it alone by themselves, and hence we need a comprehensive team of people to take part, and it's a multidisciplinary approach which is very important. So without wasting much time, I would like to go ahead and ask my first question to Dr. Snita. Dr. Snita, you are quite active in gynecological cancer treatment, as I understand. So I'm sure you have a lot of patients, and you have the task of breaking the bad news to the patients. So I would like to know from your experience how you generally go about it.
Thank you, Dr. Rucha, for the question. I believe there is no one a guidebook to answer this question. Uh, Practicing in India, I think it's very important for us to understand the social structure and the expectations from a patient when they meet their physician is very different from what we see in the West. Here, the primary caregiver or the primary doctor or the physician is the single most important person for that patient. And having said that, I wouldn't have it any other way. It is for me to break the news, and I believe what is most important is having empathy. That is the single most important thing. And let me be very candid about this, that as doctors, not all, but most of us tend to be very technical and very clinical when we are approaching a diagnosis, when we are conveying a diagnosis. And at somewhere down the line, that compassion and empathy, we tend to lose a connect. But believe me, that is the single most important thing, and this is not going to be taught to us in any medical school. It is something which is very innate, and innate to our personality, innate to our field. Compassion and empathy is the single most important thing that we need to inculcate when we call ourselves doctors. So yes, empathy, and I guess when we are breaking the news, we need to understand the social structure. We need to understand what to tell, how much to tell. It's always better to call the glass half full rather than half empty. Be a little bit more positive about the entire diagnosis, and it. More than ever, today it is becoming multidisciplinary. And to have something like this, a team of psychology experts who are going to help assist the clinician in the clinic to evaluate the patient at different time points. Not We are there for the clinical part of it. We are there to see the progress in terms of the treatment. But how is the patient taking the treatment? How are the caregivers? Are they overwhelmed with taking care of the patient? What about their mental health? So this kind of an approach, a psycho-oncology team available with us to assist us, to help us, to provide this kind of comprehensive care to the patient is absolutely welcome and is definitely the need of the hour.
in and say first that please usko sab mat bata dena. That is, it's somewhere deeply seated into our social values, and that they don't want the person to suffer. So I think rather than having a module ki this aisa karo and break the news, you have to take a call at each and every case level, look at the client, look at their caregivers, the mentality of the patient at that point of time, and then you need to take a call whether and how much you need to say. And as you rightly said, it's important about what you say, but how you say it is equally important. So that is another thing. And we have talked extensively about communication, so I'm not going to go there again. But, when we are talking about breaking bad news, as it is very important to respect the dignity of the patient, which sometimes, crowded hospitals, overworked clinicians, we sometimes tend to lose it, So it is extremely important because it is a life-changing moment for the patient. So it is important that we respect their privacy, we give them the time which is due, and also the fact that we respect their dignity when we are breaking this news to them. So whether it is a person from the oncology team, whether it is somebody from the psycho-oncology team, it is very important that we talk to them in a very peaceful manner, somewhere where it is calm, not any hospital hallway, or, and then we need to assess whether the client is ready to understand the treatment protocols and what happens next. Some people are, okay, doctor, abhi kya hoga? So, then they are kind of ready to understand from you कि आप आगे क्या करने वाले हो, whether surgery or whether it's going to be chemo or something else. And then there are people who are like, give me some time to process and I'll come back to you. So I think we need to respect that as well. And if needed, we may need to take another session to explain treatment protocols, but that is equally important. My next question is for Dr. Sukhada. And she's a mental health professional, but while she was introduced, there is another aspect of hers that she has been on the other side of the table as well. So, Dr. Sukhada, I would like to know from you about your personal experience while facing this illness, especially the emotional aspect of this journey, because now as a mental health professional, I'm sure you can look back and you have some few insights about it.
Yes, sure. And before I jump on to my story, communication, how much ever we stress, some things are still left unsaid. And a story just popped up into my mind. And I would like to share it with all of you because we are here today together talking about these serious issues. So the story is of a man who had a pet Labrador. And that Labrador wasn't well. It was rains and stuff, and he had some issues of hair fall. So this person loved his pet very much, and so he immediately took him to a vet, and the vet saw him, checked him, and said, okay, this is some seasonal allergy like thing, and I'll prescribe him something, and you have to give it to him every single day, 10 ml in the morning, 10 ml in the evening, for a month or so. Now this guy, he said, okay, fine, of course I'll do it, because his pet was like his own child. So he got to the pharmacy, he got the prescription. When he came home and opened the bottle, it was an oily preparation with a very pungent odor. And the man thought to himself, oh my God, now administering this to my dog is going to be a mammoth task every day, morning and evening, and he is not going to take it well. And it's going to be a circus for me. But still, because he loved his pet so much, he was quite dedicated. And so every morning the routine started. So first he used to chain his dog, and then he used to press the dog's head under his armpit. And then he used to open his mouth forcefully with the other hand, and then pour the liquid forcefully into the mouth. And the dog used to create havoc while taking that liquid and kick his owner and do all sorts of things there. This continued for about a week or so. One day it happened that as he was about to pour the liquid into the dog's mouth, the dog kicked hard as usual, but this time his elbow got hit and the liquid spilled. Now he was just thinking, what to do now, I'm going to spank him. His grip on the dog loosens, and to his surprise, he sees that that dog escapes from his armpit. Instead of running away, he goes near that liquid fallen on the floor and starts licking it. What does it say? Yes? See, the dog wasn't against the liquid. The dog was against the way it was administered. And this basic principle of communication is something that we all fail to understand. What Dr. Rucha was saying, the respect and the dignity of the patient and all stuff. That we need to be aware. We need to be really able to put ourselves in the other person's shoes without our own prejudices and our own thought processes about the patient, where he has come from, how he'll take it. And that is what the human touch is something that doctors can add to. So, however much we talk about communication, this thing is going to remain, that it is going to remain one of the single most important aspects throughout the process of diagnosis, prognosis, as well as the treatment of patients. Coming to my own story then, I was doing my post-graduation in psychiatry. It was my first term when I was diagnosed with thyroid cancer, and it is said that if God gave you a choice to ask for cancer, this is the best cancer you can ask for. And I was fortunate enough to have been diagnosed with that. However, see, on some level, all our psychology is the same. So initially, I too, my mind troubled me with all the questions like, why me? Where did I go wrong? मैंने किसी का क्या बुरा किया है? Why did God punish me? Why at this age? What about my future? Will I get married? Will I ever have children? All kind of stuff. And unknowingly, these things pull us down along the way. So after the diagnosis, see, things which are bound to happen with us, they do happen. So surgery and everything, it happened routinely. But as the saying goes, pain is inevitable and suffering is a choice. I had invited a lot of suffering to myself. Because somewhere here, I believe that my whole life is gone now. I will never be able to live a good life, a healthy life, a complete life, so as to say. And then after everything, my interest in reading increased, because at that time, I got exposed to some very beautiful books suggested by my friends, some of my seniors. And one of the stories which I had read, which actually helped me change my perspective of looking at things, was the story of Arthur Ashe. Many of you might be knowing that story, but for those who don't, I'll share it in short. So Arthur Ashe was the first black to win the Wimbledon title. And at that time, where racism was very rampant, and Wimbledon was not even considered a game of the blacks. So at that time, he was the player who won the Wimbledon title, and being a black, again, he had a universal representation and fan following. Unfortunately for him, a couple of years down the line, when he was playing really well, he was at the top of his game, he was diagnosed with HIV. And that too he had acquired from a heart surgery that he had undergone. Now the doctor told him a couple of years, because at that time there was no established treatment for AIDS. He received letters from across the globe, and all the fans had expressed their grief. And one fan had written very, very closely that when you go to heaven and meet God, please ask him, why me? Why did he choose a person like you for such a dreadful and bad disease? So please ask him. And Arthur Ashe, the kind of man he was, he gave a very beautiful answer to this. He wrote down, my dear friend, it is your love for me that is speaking right now. But you know what? If at all I go to heaven, and if at all I get to meet God, I'll never ask him why me. Why so? See, he wrote this down in the letter, and it's available on the net if you want. 5 million children start playing tennis, is what he wrote. 5 lakh of them reach to a level where they play professional tennis. 5,000 reach the Grand Slams. 500 reach Wimbledon. two reach the finals, and one wins. I was that one who won. And 4 years back, when I was standing with the Wimbledon title in my hand, at that time, I did not ask God, why me? So today, if something untoward has happened in my life and this has come to me, today I don't have any right to ask God, why me? Now, most of us will argue that what about the hard work that he had done? Wimbledon was not given to him by God, but something like AIDS was just given without any fault of his. He has also answered to this query. He said, I did my part of hard work, but being born in a family where in spite of being black, my parents always supported me to play, me having a good coach, right from that point to the last point in the match, wherein my opponent played his weakest game and I could play my strongest shots, was not all mine. And now I should have the grace to accept the way I accepted the Wimbledon title. So the story actually helped me change my mind or change my perspective or my approach of looking at things. And the resistance came down. Over the next couple of years, being a mental health professional, of course, having access and interest in all these therapies, I understood the importance of mind and my approach and how much it could do. And to my surprise and to all of your surprise, after 4.5 years, I had a kind of relapse with my lymph nodes. And at that time, I again went to see my oncosurgeon and I was sitting in front of him and he examined me and blankly said, surgery. And at that moment, I can look into all of your eyes and tell you very, very straightforward, without an iota of disturbance inside, I asked him, when should we plan it? So probably that acceptance had increased so much, all that resistance, the unnecessary fighting had gone down. We all forget one thing, that as long as we keep fighting our mind, we have less energy to fight or to deal with the cancer itself. So another sentence by Randy Posh, probably from his last lecture, that had helped me was that cancer has afflicted my body, I will not let it afflict my mind. And these things definitely helped me in the journey and the relapse, and after that, touchwood, things went normally. But what is important is what I experienced in the first round of all the things that my body and mind went through was resistance, was fighting, and was inviting suffering and pain at every step of the way. And in the second part, what I experienced was an amount of grace, that if it has come my way, as Dr. Agashi was saying, let me see how I can befriend it, and instead of fighting my way with it, let me see how comfortably I can go along with it. So that was in short my emotional journey with cancer. Thank you.
To just sum up your journey, Sukhada, I'm sure you would agree with me. When dealing in mental health, there is something called as stages of grief or stages of loss that we are taught, and I just explain it in short, that there is the first stage of denial, then there is a stage of anger, then there is a stage of bargaining, then a stage of depression, and finally a stage of acceptance. So these are the 5 stages of grief which a person goes through when he faces a loss. And as Sukta just explained, each cancer person in their own way goes through these 5 stages of grief. Some of them may not reach the stage of acceptance, but I feel it is the duty of the treating team and the psycho-oncology team to make this emotional journey palatable for them, so that they are in their own way able to reach this stage of acceptance. So the stage of acceptance can actually come at any point of time,
True.
It can actually come even before the start of treatment. Sometimes the patients they come back after the initial session and they are in a very changed state of mind, and then the treatment definitely goes much better. There is something called as psychoneuroimmunology, which we are all aware of, and that also plays a part in how patients respond to treatment, I feel. My next question is for Dr. Reshma. She deals with pediatric hemato-oncology, but I would like to ask you that, you deal with a lot of children. So how is your experience when, you talk to children about their diagnosis, to their parents about the diagnosis, how they face this treatment, children, because I'm sure they react in a very different way than that of adults. We'd like to hear from you.
Yes. So, Rucha ma'am, like you rightly said, children deal with this diagnosis of cancer and all in a very different way than adults. And we'll be talking about children and then about their parents also. So, what happens about children, those who are very young, like less than 6 or 5 years, they don't really understand about this illness or what is going on around them. What is it that they just make up an image of a doctor, like, someone in a white coat, someone who's like maybe like a monster to them, coming and poking needles into them. So they make up this image and they are very, very fearful when you come for the rounds and, they get scared of you, they'll hide behind their parents. So as a pediatric oncologist or as pediatricians also in general, what we need to have is a friendly approach towards these children. So they are not scared of you. So they are able to understand, they don't really understand what treatment and all they are undergoing, but at least we can have a friendly approach towards these children. And in this age group, the parents will be more important. Now the age group of children 6 to maybe 13, 14 years, they do in a way understand that something is wrong with them. They are having some serious sort of illness because they undergo multiple sessions of therapy. They do understand in a little sort of a way. And in these children, sometimes we observe that during this treatment, they may become a little quieter or they may not talk much. Their growth and all is also affected sometimes. So what is important is understanding that the signs of psychological illness in children and adults are different. So we must be able to recognize these subtle signs also, and again similarly approach them in a friendly way, in which they also know that the doctor, they can be comfortable with you as their oncologists, as their doctors. And then coming to the adolescent and the teenage age group, again, they also form a very difficult group because they understand. They may sometimes react in a different way, like they may be irritable. Maybe Marathi मध्ये आपल्याला म्हणता येईल चिडचिड करतात. So they may react in a different sort of a way to these diagnoses and all. Now the common cancers that we see in this age group are generally blood cancers. And the second, one of the common cancers that patients under me are also bone tumors, because bone tumors are also very common in this age group. So their growth in girls, maybe the menstrual cycle, everything is so important at this age. So everything needs to be taken care of. And the children should, whenever we come for rounds and all, we should make sure that the children are not scared of you. They are actually happy and they smile when you come for the rounds. That should be the way you should make your patients, your pediatric patients, so comfortable and happy with you. So a friendly approach really matters. And then, as far as the parents are concerned, for these pediatric patients, the parents are actually the more important group for us, because the parents themselves get so psychologically affected. It is so difficult to counsel the parents also. Sometimes the younger children and also even may not be understand so much of stress that they are going to. Children actually are not really understanding all this, but the parents do get affected a lot. I have really seen, even when I'm just putting a small needle also, the parents themselves start crying so much. So it's maybe I would say, the most difficult thing in the world is to be a parent, because it's not really easy to see your child suffer in all this. So the role of psychology is very, very important, because the parents need to be counseled. And what I generally tell them, this is a very temporary thing, that you see your child suffer. He's going to grow up, because most of our childhood cancers are curable. So that is the good part. Most of them are curable. They are going to be normal children. They're going to grow up, have a good professional and a personal life. It is just this temporary part, temporary few months or maybe a year. If you see your children go through this treatment, they're going to come out as very, very normal adults and cancer survivors, and normal, just like all other people live their life. They're going to live their life normally. So it is this part in which if we support them psychologically and in other many aspects, they will be strong, they will help their children fight this illness, and ultimately these children will also go up into normal cancer survivors, normal adults.
Thank you, Dr. Reshma. No, it is, I'll just share a small experience. While I was working as a psycho-oncologist with a cancer care center, there was this 6-year-old boy who was taking treatment for the past 6 months. And unfortunately, as you know, these treatments are quite extensive, so this child started missing upon school. So my treating oncologist just was talking to me, there is this kid here now and he's been coming here for such a long time, and he gets bored and we just don't know, how to entertain him and, keep him up, keep up his spirits. So is there something that you can do? So I got talking to my psychologist and social worker, and I got talking to his mother as well. And then we kind of came up with a plan where, for each and every chemotherapy, we would give him some sort of homework from his school textbook, So he would, we had just named these chemotherapy cycles as आज geographyचा lesson आहे, आज मराठीचा lesson आहे. So then he would go home from the chemotherapy taking some homework along with him, and then he would bring back the homework, and then, we would sort of make it a way that the treating oncologist was the teacher, and then sort of, giving the teacher the homework. So we tried to make it as normal for the child as possible. So as Dr. Reshma was very rightly saying, that, you need to remove that fear from the mind of the child that he's going through something which is very different. Another experience which my colleague shared from Tata Memorial, these children, there is a very big children's ward there in Tata. And these children are very excited to come for chemotherapy. And then she just was talking to them, how is it that तुम्ही एवढे कसे का खुश असताना, coming for chemotherapy? They say we don't get to go out of the house. We don't get to meet children our age. So this is the only place where we get to interact with children. So that's what makes us happy, So the way we look at things and the way children look at things is so different. So, what again you said, the parents are the ones who really bother. And even though really young children do not understand the significance of what they are going through, they definitely understand that there is something wrong when they see their parents upset. So it is extremely important to tell the parents and counsel the parents, talk to the parents, get them to understand that this phase is very temporary. And they need a lot of hand-holding more than the children. The children find their ways to enjoy their time in the hospital. It is the parents who need a lot of support in these times. So again, effective psychoeducation from the psycho-oncology community at the outset of the treatment for these children is very important, because sometimes then the parents tend to skip chemotherapy cycles, or they tend to not come at all. And then this again worsens the chances for the child. So it is important to psychoeducate the parent as well as the child in a language that they will understand. So when I talk to children, I make sure that I tell them a story about a war. So there is a war going on inside them, and how they are the hero. And there are really wonderful videos. I'm sure some of you must have seen them. These are all from the West, of course, but then we can definitely Indianize them. That there is a war scenario shown in these videos where this child is the hero, and how, all the WBCs and RBCs and everything, and how chemotherapy is helping them. And so it makes the child aware of what they are going through, and then you can weave all the treatment modalities into that story for the child and make it palatable for him. My next question for Dr. Kannan, sir. Sir, the fear of recurrence is there in the mind of every survivor, for whatever cancer they may have faced, for however length of time they may have faced it. So addressing this fear is, I think, very important as well, when, you tend to say to the patient that you can come back to me if and when you have something wrong. So how do you go about it, sir?
I think this is one of the most difficult questions to address. Also because many of the times both the patient and us, both of us know that once it recurs, you might not actually be in the curable bracket that it could be. And that's what it makes it more difficult. And as a doctor, I can also tell you that though we can sort of prognosticate, say that, okay, you take this treatment, you will get cured. But for a particular patient, we also never know what the end result is going to be. So in one way, we are actually undergoing the same journey that the patient is. And for that patient, we never know, even after the treatment, whether he's going to get cured or is he going to come back to me with a recurrence. And partial advantage would be that the patient is much more educated about the disease, the prognosis, the complications that he has to face when he has to undergo treatment. But I think it doesn't make it easier neither for as a doctor or the patient that the disease has come back. And like Dr. Sukhada says, it again many times starts with why me, why the disease has come back, and why I have to go through with all I have already undergone for a second time. And I think we don't have one simple sort of easy counseling that we have. We have to be forthright, we have to be honest with the patient as to what practically he has to face and expect from both the disease and the treatment. But I think the one thing that we can never take away would be the hope from the patient. It has to be done in a way that we still don't take away that. Because truly we also don't know. It's very likely that the patient can get all right also. And that is the way it has to be approached, is what I would sort of say, this is what I would do. And I think as a crutch, or even thankfully, I think the Indian philosophy of life, I mean as against the Western philosophy of life, it also helps us saying that whatever said and done, this is still a journey, and this is part of if you sort of believe that you are the spirit and not the body, and that can also help you in approaching the disease and the treatment, right? I think that's how I would probably do it. So for people who can understand a little bit of spiritualism and God, that also helps both me as a doctor and the patient also to go along this journey, is what I would feel.
I know, sir, it's an extremely difficult issue to address in cancer care about the fear of recurrence. But as sir rightly said, we as clinicians should also keep this in mind, that we are not all knowing. Because if we have this thing in mind, this is the best that I have given, but I don't know what is going to happen next, it keeps us grounded, and it also helps the patient see this reality through our eyes and through the way in which we talk, what we tell them, how we communicate it. Because sometimes we as counselors have clients who have had somebody say a few things which were not very relevant or not spoken to them in the right manner, and then they unfortunately hold on to it. We'll come to that next, but what we were talking about previously about academic research and how it needs to be very sound. We can find information on Google, whatever we want, however we want it. If you say, if you type onto Google, can I get cured of cancer? There will be first few sites which will say, yes, you will definitely get cured of it. And then they hold on to that. That is what unfortunately hope is. But we as clinicians need to provide them ground reality without hurting them, and we need to be honest with them as well as with ourselves, and need to tell them that this is a fact, this can definitely happen, recurrence can happen, but we are there for you. I think this message is very important to convey to the patient, that we are there for you as a team. If and when you need us, we'll always be there for you. So even if you feel that there is something going wrong with you, please don't hesitate to come and talk to us, because clients are very often scared of coming back to the oncologist if they feel a node or something somewhere, and then they are like, "Ki, chodo na, baad mein jaake dekhenge," ya, oh my God, what if it is back? And then I don't want to go through it again, and then they just let it go and then it worsens. So we need to give them this message that we are there for you. I think that is very important. Another aspect where we are all dealing as a team is the quality of life. I think, the oncologists deal with the physical quality of life, we deal with the mental, the social quality of life, and, everything together. So, oncology treatment as such helps the client to improve their quality of life also. So, my next question is for Dr. Snita. You deal with a lot of surgeries, some of them may be mutilating, some of them are appearance altering also, the issue of body image which we talked about. And these surgeries definitely have an effect on your self-image. So as a result of this, there are a lot of clients which come up with sexual issues, intimacy issues, relationship issues, and these issues do not directly relate to the cancer treatment, so they may not be talked about that often, but they are equally important. So do clients actually open up about these issues with you, and how do you go ahead with them?
Dr. Rucha, this is a very important, very, very important aspect now, especially in 2023. I'll tell you, a decade back, probably it was, the word cancer and doctor, I want to get better. But now with advances in treatment and our patients living longer, I want to get better, and I also want to have a good quality of life. I want to enjoy my life. This is a very important aspect that the treating doctor has to keep take into account and keep in mind. Again, I would emphasize on the social structure. Okay, ours is a very diverse country with diverse population and various levels of society. There is one strata of society who is not really bothered about enjoying life, but who's really bothered about getting better and getting back to earning his livelihood. And there is one strata of society that is concerned about getting better and also concerned about enjoying life and enjoying a good quality of life. So we can't really have a protocolized or protocolized approach to this. It has to be a very tailored approach, understanding the social structure, understanding what that patient needs, what is more important for that patient. This is one aspect. And coming to your question, no, very sad. Patients don't. I'm not talking about one strata. I'm talking about the educated strata also. They don't come and discuss with us about these issues. Very, very seldom. They won't come and talk to us about their mental health, sexual health. Yes, a lot of them are mutilating. Dr. Kopikar already emphasized earlier that how the first thing is with the inhibition. I've got a lump in the breast. Oh my God, I think I'm going to undergo a mastectomy. I'd rather not go and see the doctor. The story ends there. Okay, so getting now, of course, with the awareness that all is not lost, and you can save organs, you can preserve organs scientifically, with evidence, that organ preservation is being given a lot of importance in various subsites of cancer. Things are changing, but post-treatment, during treatment, on follow-ups, very seldom. The focus is, doctor, how are the reports? Is my cancer going to come back? Is everything in the clear? But when we ask the patient, how are you doing, it's not with the intent of knowing how we know with the reports how you're doing cancer-wise, but how are you doing? Okay, and partly we are at fault because the focus is so much on treating the patient, and for us the victory is, oh God, I've cured this patient of cancer, she's lived 5 years and the cancer has not come back. But how is she living? As doctors, down the journey, even we fail to ask that. So I guess we need to work together on this. I'm certainly, we are looking at, when we look at academics and quality of life being introduced, it's not a very regular aspect in our clinical care. Research, unfortunately, has not been given a lot of importance right from med school. With the kind of education structure, but as individual doctors, most of us are now integrating research, academics into our clinical practice, and quality of life evaluation, not only for the patient but also for the caregiver, is extremely important. What have they gone through these 5 years looking after the patient, coming for chemotherapy sessions, being there post-surgery, being there during the rehabilitation? What toll has it taken on not only the patient but also the mental health on the caregiver? So these issues need to be addressed. Unfortunately, the awareness, the forthcoming nature is still not there. Patients don't approach us, they don't ask us, they don't inquire, they just accept. Okay, but how is this acceptance? Is this acceptance really affecting their social life, their interpersonal relationships? Is something that, if you ask me, I really wouldn't know.
It is unfortunately, very sad that people tend to go through a difficult patch during this phase of cancer in their lives and their interpersonal relationship, especially with their spouse. I've heard from patient stories about the husband sleeping out of their marital bed just because the woman is undergoing chemotherapy and you don't know ki kya hone wala hai uska.
Yeah, Dr. Rucha, these questions do arise. Is it communicable? I have children at home. I have elderly patients, elderly individuals at home. Can I be in the same room as my wife? So these questions do arise. So this is just the tip of the iceberg. Absolute tip top. You can gauge the attitude and the mental where the direction of this individual or the caregiver is going. So it is at that point of time. Okay, now there might be hurdles in their interpersonal relationships. That is when the clinician has to be aware. That is when you need to probably have a team who's going to be able where you can direct this individual. I might not have the time to sit and address this issue. Okay, that is where, but what I have done is probably understood, grasped that, this could be a potential area where the family as a whole needs a discussion. So let's send them to a team, where somebody will sit with them and address this issue, which has not been happening very frequently, which is not happening, and I think is a very important point and aspect that we need to address today.
I really understood this very important thing from you, that the oncologist also needs to be aware at which point the family or the caregiver or the patient needs to be referred to the psycho-oncology team.
So.
It may not be needed at the beginning, but then when such questions arise and they are not going to say कि भाई दिमाग का कुछ हो रहा है तो please भेजो ना, वो नहीं बोलने वाले. The oncologist needs to identify the subtle questions and the direction of the questions and understand about when the clients need to be referred.
And I guess in the future, our success parameter is not going to be how many successful surgeries I have performed, but my patient walking in telling me that after this surgery I am living a wonderful life, doc, thanks.
Absolutely.
Okay,
absolutely.
That is exactly that is what the future benchmark and probably the future definition of success for me as a treating oncologist, as a treating cancer surgeon would be. And I guess this should be a part of our training, our understanding of this disease process and what it actually does to an individual.
Right.
Just small addition I'd like to make. Whatever Dr. Smita had said makes absolute sense. But see, what happens is whenever a person is diagnosed with cancer, all we see in front of our eyes is cancer. So it's very, very important that we differentiate that cancer is a part that body is carrying, nothing beyond that. But we usually don't do it because of the severity of the illness or the extent of the treatment it's going to take, or probably the risk of life that it's carrying. We generally start equating the person with cancer. So this person becomes cancer. That is how the person looks at self. So I had once talked, let me just, so Rucha, I know you have a daughter, right? And what do you call her at home?
Mau.
Mau. Oh, such a sweet name. So Mau means cat in Marathi, those of you who don't know. So suppose she has fever someday. What do you call her?
I'm sorry, I didn't get you.
Suppose Mau has fever.
Yeah.
So what do you start calling her when she has fever?
No, I think it would be more, cuter names or something like that, to caress her and...
To Betu, sweetheart, Mau,
Absolutely.
again the same?
Right.
That's it?
Yes.
You don't start calling her fever? Fever, how are you?
Why would I?
Why would I? That is the question. So if my child has fever, I don't start addressing my child as fever, what is happening to you? Because I know that fever is a part of the process, the body. But with diseases like cancer, this doesn't happen, and that impacts the quality of life in the long run. So while we are talking about the quality of life, it's very important that we start differentiating life or the living person from the disease that he or she is carrying.
We are coming to the end of this session now, so the last few questions, but then these are equally important. Now, there are few times when the intent of treatment changes from curative to palliative, and that is another important step or a turn in the cancer journey, which again has a lot of emotional issues. So my question for Dr. Kannan is that, whenever this journey changes from curative to palliative, there are a lot of issues that arise in caregivers and patients as well. And there are some times when, the patients are really not going to make it. So how do we give them a dignified death, sir? Do we really think about these things when, the patient is there, when he's actually alive?
Yes, it's an important thing, and I think, thankfully, giving somebody a dignified death, I think, is part of the teaching. But how to go about it, that's a totally different thing, and I don't think that is an easy thing at all. But yes, it is part of, and I don't think there is one thing, but ultimately it's your empathy and your connect with that patient which will help you, because each person is different, his expectation is different, and likewise his balance with the family might be different. So there might be a family which can really take care of him and help you out much easily, and there are also situations where the family might not be there to really put in that kind of care. So again, it becomes an interdisciplinary thing with you and the whole sort of treating team, which should involve psycho-oncologist also there. Because it doesn't just end with counseling for just the treatment or how you approach that, but also can you leave a will, have you done that? So all those issues also should come into play, and for one person doing everything obviously is not easy, right? So I think it's the whole team which will come together and help you out in those kind of decisions.
Again, I think
And again, the other part, this is the patient facing death. Again, the family members looking at a loved one facing death. So again, those people will need help, yes.
So again, the fact that we need a multidisciplinary team is re-emphasized by Sir. And it's not just the psycho-oncologist. We need social workers. We need trained volunteers. We need survivor champions. Also in this multidisciplinary team of psycho-oncologists, it's going to be multiple people working towards helping one patient and their family. And now coming to the most important part, Dr. Sukhada, about the oncologists and their mental health, which is brushed under the carpet so very often, and I see smiles coming from you, so I know it is. But caregiver mental health and mental health of oncologists is extremely important, and it needs to be addressed, I feel. Please.
So it's the elephant in the room, I believe. The mental health of not only the cancer patients, but their caregivers, the medical professionals associated with it, and the entire teams running around it. So I'll just give you a couple of words and let's see what emotions come to your mind, okay? So all you have to do is just visualize those words, right, in front of your eyes. Okay, so cherry tree in full blossom, cherry blossom. Oh, you don't have to say it aloud. Just imagine it in front of your eyes and experience the emotion that you have. A big cobra. Okay. An infant giggling with its mother cooing to it. A 3-year-old boy with terminal cancer taking his last breaths. So, did all of you experience that array of emotions within your mind? Now, we did not have anything in front of us actually. What were all these? Just words. I'll give you another specific example. See, a couple of decades back, children with subpar intelligence, what did we call them? Mentally retarded. So now just see, I'll take 3 words in front of you and just see how you feel listening to those words. So what we used to call them a couple of decades back, that this child is mentally retarded. Then things changed. It became a bit more subtle. And then a different word came. So now I'm saying this child is mentally challenged. And now, coming to today, what we say, this child is special. Did you feel different emotions each time? We did. Now the child is still the same, but mentally retarded invokes different emotions in us, and so does special. So just imagine if these few words are enough to generate an array of emotions with bodily responses, and it's all one part. Our immunity is there, everything is built in there. So what must be happening to those people who are living or who are fighting that fight every day? So let's not anywhere do injustice to this word, that mental health matters. And it is the prime thing that matters right from the time this word marks its entry into your life. Let's say, for example, I bring an astrologer here who is 100% correct with his predictions, okay? And he diagnoses that on the occasion of this, I predict that all of you leaving this room will be leaving with cancer. What is the first word that came to your mind? Answer very, very honestly. Death. Anybody else? I'll have company. Good one. Yes? I'm not alone. What else? Come on. Something has come to your mind. Pakad ke maro, kya baat hai? Probably I need to shift my seat now. Yeah, you're astrologer probably. चूक झाली असेल, excellent. So his prediction might be wrong. No, cannot happen. So let's start with addressing this, that this is important. Denial is not going to help. And let us always also start prioritizing that instead of just looking at my body parts and the treatment and the schedules and appointment, what is going to help me take these challenges well and face all these treatment protocols better. And that is ultimately again going to be my mind.
So again about caregiver burnout as well as compassion fatigue, two terms which we tend to ignore, but then again they need to be addressed. I'm not going to go in detail because we are short of time, but my final question is for Dr. Reshma. We have been talking about research for quite some time now, right from the inauguration. How important do you feel is, sound academic knowledge before you enter the field? Because we hear a lot of times, कि बात करने में गलती हो गई and then things just took a turn for the worse from there. So what's your take on this?
Okay, so answering in a short. So like we were just talking about caregivers, recently we had a conference, American Society of Clinical Oncology, in which I presented an abstract. The abstract was about if there is an intervention in caregivers, the caregivers are the ones who take care of the patients. If there is an intervention, that is a team of psycho-oncologists also talk to them. See how much stress they undergo, assess their anxiety levels, depression levels. And if you intervene in a group of caregivers, that you intervene as a team of psycho-oncologists, you counsel, there is some counseling sessions and the way psychologists treat them. And in one group, we don't intervene. So what is the difference? So there was quite a lot of difference in outcomes. This group did fairly better than the other group. And that also led to improvement in patient outcomes. So you understand how much important is also a research in this field. And also important is the mental health of the caregivers, patients, and also maybe the oncologists also. So this is one part. One more example which I can give you all is how much importance of this psycho-oncology is out of India also. See, I have given my exam of Royal College of Physicians, London. So that is the degree which I also have. So when I gave this exam, just I'm giving an example. So when I gave this exam, we had British examiners. And the exam was divided in 5 parts. So one part of which was breaking the bad news. And this was never, when I gave my MD and my DM exam, this is sort of a exam we never had. So a British examiner was sitting like that and a dummy patient was in front of me. And the examiner would just observe how I break the bad news. So the patient, I didn't know, they are really trained, they are dummy patients, so they were really trained. You never know how they react. And the way in which I break the bad news and counsel was also judged. And we were given marks on that also, and then we really get this degree. So I wish that sort of some small part of academics is also included in our training in India also, because this is so important. So we as oncologists even more, because the way we deal with patients, I think ma'am pointed out in the beginning only, empathy has to be very important quality that we should have. And sensitivity, sensitivity. It is not just, hey, diagnosis, and you are Zala, that's all. That is not the way. You have to have an empathetic approach. Try to imagine, like, Dr. Suvida was saying, imagine yourself in their shoes also. How would you feel if someone just, directly in a very insensitive way talk to you? So you have to be sensitive, empathetic. These qualities should be instilled in an oncologist even during our training also. So this is an important part that should be in our training. And mental health and all, of course, of our patients. And what happens is, like, as a practicing oncologist, I see we are very busy in our OPDs. So we are really focusing on the clinical part, treatment, side effects. We are, so much busy in all that. We have a long OPD. So I really wish it is a multidisciplinary team. We also have I wish I also had, sometimes I feel, I wish I had a psycho-oncologist with me whom would also be there as a part of the treating team, and who would also take care of the psychological needs of the patient, like I'm taking care of the clinical needs of the patient. So having a psycho-oncologist in our team is really very important.
Yeah, I just want to make one quick comment on this. We need a team, but this team is going to be a bridge between the clinician and the patient. The reason I'm saying this, because the social structure in India is very, very different. The expectations from the patient is that the doctor, I am the treating doctor, I have to be with the patient through the entire journey. So let us not forget at any single point of time that we are handing over the patient, even for the mental problems or mental counseling, to the psycho-oncologist. The clinician has to be there very much involved. It's like the mother, the father, and the child. So the father is there, but for all the problems, the child will go to the mother. I don't know whether it's an appropriate analogy, but yeah.
Such a nice way of coming to the end of the session. So as I always say, you know, psycho-oncology is a marriage between oncology and mental health. And as you put it very cutely, it's like the mother and the father. So yeah, so it is definitely a multidisciplinary approach, and we see that the oncologists also feel the need here. And I think I would like to end on this note, that all of us are trained professionals, but we also wish to get trained in the field that we are not. So even though I am a psychiatrist, I do not have a formal training kind of, you know, what they say, ki bhai aapke paas certificate hai kya? So there is nothing available like that in psycho-oncology for trained professionals. Everything is focused on psychologists, but there is nothing focused on trained professionals who wish to do something new in a different field. And I think this course is going to be something which is going to be, you know, it's going to set up some really nice standards for people who wish to learn something new and continue learning throughout their process as clinicians also. So any last closing comments from the panelists would be welcome.
Nothing's really changed. It's just old wine in a new bottle. The main crux of psychology is not going to change. It's just that we are getting the oncology aspect of it.
Right.
Okay, and it's not because of the lack of your presence. It's just because of the lack of our involvement of yours in our patient care. That's the only thing. That's what I would like to emphasize.
Can I say something?
Please, please.
So I totally agree with your, and so with our effort towards education, we want to train the trainers. That's one of our efforts that we will. And in our research we have found that for every oncologist in India, we need 2 psycho-oncologists to help them, like she said, co-parenting. So that is our aim to, if we can get more and more psycho-oncologists trained, then we can support oncologists who despite of having training in handling big numbers of cancer patients, are still trying to bridge the gap between the communication. And I think we can carry that conversation forward with our education efforts. So that's very much on our mind.
Nasneem being in my clinic once, and she came to me and she told me that, you know, we would like to do something. I said, you can't do it without the in the absence of the patient. If I am counseling the patient, I'm diagnosing the patient, you have to be over here, because you need to understand what I'm telling the patient. It's not going to be with you sitting in another room. It cannot happen that way. So she has to be there beside me. That's exactly what I told her. You know, she has to understand the nuances of what diagnosis is being made, because it's one team talking. We have to talk the same language.
Yeah. You have to be communicative.
Right, talking the same language.
Right.
And the language that I am going to be, literally, it's going to be in the language that the patient understands, and in the language that the psychologist also understands.
So somebody to bridge that communication gap. Yep. Thank you. Thank you.
We'll end the session here, and our best wishes to this new and upcoming center. And I hand over the mic to the organizers. Thank you so much for inviting all of us. Thank you.